Hello and welcome to Health Matters on Channels Television. Thanks for joining us. I am Mary Alale Yusuf. There are now almost 66 million confirmed cases of COVID-19. That's an increase of more than 4 million infections in 1 week around the world. By December the 4th, global recoveries were over 42 million and deaths over 1.5 million. In Nigeria, there are over 68.5 thousand infections. More than 64,400 people have recovered and 1,179 have died. Recovery rate is about 94%. Case fatality rate is 1.7% and almost 800,000 samples have been tested. Now to the topic of the day. In 2014, the Joint United Nations Programme on HIV Aids, UNAIDS, and other foreign partners launched the 90-90-90 strategy to help end the AIDS epidemic by 2030. The idea was to diagnose 90% of all HIV-positive persons, provide therapy for 90% of those diagnosed, and achieve viral load suppression for 90% of those treated by 2020. How have we fared? My guest on the show, speaking from our Kano studio, is the DG of the National Agency for the Control of AIDS, Dr. Gambo Aliyu. You're welcome to the show, Doctor. It's been such a long time.
Yeah, Mary, pleasure to be here and pleasure to be with you once more.
So let's get right into it. The 90-90-90 target means that 73 out of every 100 people should have achieved viral suppression. How are we? Where do we stand in Nigeria?
Where we stand in Nigeria is in the first 90, we're faring, I can say well at the moment because we got to know where we are in the epidemic just 2 years back. And at the moment we are about 73%. For the second 90, we are 89, close to 90, and for the third 90, we are about 78%. Let me explain. The first 90 is the most important 90 upon which the rest of the 90s that follow it lies. Simply because you're looking at the people you identify and you look at fraction of that people you identify and getting them on treatment, and you look at fraction of those on treatment to see that they get the viral in them under control. For the first 90, we have identified 73% of people living with HIV AIDS and are aware now of their HIV status. And of those 73%, we've identified about 89% that we have linked to care, and they are taking treatment at our treatment facilities. Of those 89%, of the 73% that are taking treatment at our facilities, about 78% of them are having their virus suppressed. So looking at it, I cannot tell you that we have achieved the 90-90-90 and now we have 73% of all HIV people that are present in Nigeria having their virus suppressed at the moment, and we have about maybe 27% at risk of spreading the virus. Nonetheless, we have done tremendous work over the last 2 years in getting to identify individuals, that have this infection, and at the community level as well as facility level, to bring them to where this treatment are being given, and also to sustain them on treatment to have their virus suppressed. At this current momentum, we are very hopeful in the next 2 years we will reach the final 90 for the first 90. That is the final boost on the 90 mark. And on the second and third 90, I think at that moment we should be hitting 95.
Okay. Let us quickly define viral suppression, because I know you link people to care. but not all of them have achieved viral suppression. So what exactly is suppression?
Literally is the situation where the individual has controlled the virus in him or her to the extent that the virus doesn't leave that individual to affect another person that is not infected with HIV, and it doesn't give the virus chance to continue to grow to the extent that it breaks down the individual immune mechanism to make the person sick.
Okay. Can you tell us what was holding us back? Why didn't we hit the target by this year? What are the factors that made us not to get there?
Right. So it's a combination of factors. One, our program is nationwide, but before now it is centered at facilities. It is only the last 2 years that we have taken the program to the community, having realized that some people will never come to facility to test, and some people will never come to facility to take treatment. The best thing is to find a way to meet them halfway, and meeting them halfway is getting closer to them, going out to the communities and meeting people, explaining to them why it is important to know their HIV status and why it is super important for them to do something about it after knowing their HIV status. And your HIV status could be HIV negative when you test, but now you have a burden, the burden of remaining HIV negative for the rest of your life, which qualifies you to our prevention package. And if you don't test, you will not know what prevention package, what packages, what R2 package may benefit you, either the prevention package or the combination of prevention and treatment and care package, which is offered to somebody who tests positive for HIV.
Okay, so people say that COVID-19, when it came, disrupted a lot of things, delayed a lot of things, spoiled a lot of things. Has COVID-19 affected the response to HIV AIDS, and how?
It has impacted negatively and positively. During the lockdown, COVID-19 denied us the opportunity to identify people the way we identified them before, and denies us the opportunity to give medication to those that were on medication, deny us the opportunity to do the routine viral load testing to determine the level of virus in them, also denies us the opportunity of moving our commodities around logistics, and also denies us the activity of having the healthcare workers at the facility, and having some of the facilities also closed because some of them were converted into COVID centers. Having said that, I want to also say COVID-19 has impacted positively on our program and our system, because before COVID-19 we have about 25 laboratories all over the nation where viral load testing are done. Today, I can say we have over 70 of those laboratories, most of them located within states' facilities, where viral load testing are given, which is very important for us for sustainability. Going forward, we want states to be in control of their program, and now states are much more empowered to control their program and to coordinate it and to do their viral load testing and tell us about these important indicators in their respective states even before we tell them what we have nationally.
Okay, so if we get to achieve that 1990 goal, and 73 people out of every 100 has viral load suppression, can we, on the strength of that, eliminate HIV AIDS? Or is there some other plan coming up after 1990?
We are not talking of eliminating HIV AIDS per se. All we are talking at the moment is controlling HIV, controlling and sustaining that control. What is important is if you identify 90-90-90, which means you have about 73% of the people that are capable of giving this virus to others now able to control the virus and keeping the virus within them, then now you move to 95-95-95. And what that means is that 27%, when you achieve 90-90-90, that is now capable of giving the virus to others, that proportion is further reduced by half, which means you have about 86% of your population that have HIV unable to transmit HIV, only about 14% of them that are at risk of transmitting HIV. From 95, it is expected that the response is sustained, and these people will be identified, though not at the rate at which you identify them now, because they will be scarce at that time. At the same time, transmission will be almost eliminated. You're not going to be seeing new cases of HIV, and death from HIV also will be rare. We won't be seeing it. At that particular time, then the task is keeping the HIV within individuals that have it and letting them live with HIV up until the time when we are able to find either a cure for HIV or a vaccine for HIV. And if we continue to live with it, then it continues to do well in only people that have it, and letting it to remain within them and denying it the opportunity to leave them and affect other people that don't have it.
We seem to have a sticky problem with key populations, especially men who have intimate relationships with other men. But then also the drug injectors, you know, we seem to be having a sticky problem with them. Are we going to be able to reach those people, or can we achieve this goal in spite of them?
Generally, we have problem with men, whether they are men who have sex with men or men who have sex with women. We have problem with men in general. But yes, you're right. We have also problem with key affected population, and key affected population are the population you're calling. Men who have sex with men, those who inject drugs, and transgenders, as well as female sex workers. Because of the importance of this population, right now we are having a survey that is nationwide to determine their size, to locate where they congregate, and to identify ways to reach them in a more easier way than we have been in the before now, and at the same time to find out what type of program work best for them, simply because without getting to work with this group, without this group buying into our campaign, without this group volunteering, coming out to test and propagating this self-testing among them, and without them coming to take the medication, our ability to control the virus in the near time we targeted will be very, very difficult. And that said, but let me come back to men also. Men generally don't want to test for HIV, and we don't see them. We see female more than men, and this is disturbing. It's disturbing in the sense that there is just no way we can get to control HIV without identifying these people amidst us, who are now up to about 500,000 by our estimation, that are either not aware of their HIV status, or they are aware of their HIV status but not coming forward to take our services, or not coming forward even where they don't take our services, where they have services they can privately access. They're not accessing them. So this is worrisome.
Okay. I think we'll just take a short break now so that we don't overshoot our break time. When we come back, we'll continue with this discussion. Please stay with us.
No, this one has dropped.
Welcome back. We're still on Health Matters on Channels Television. We're talking about AIDS with Dr. Gambo Aliyu in Kano. Let's continue with the conversation now. Does it strike you as odd? People have been saying that they gave so much attention to COVID-19, and COVID-19 doesn't kill like so many people as AIDS, yellow fever, and other things. Why is it getting so much attention? Do you think that AIDS has been neglected, needs more attention? And does it strike you as odd that we don't have a vaccine for HIV AIDS, but we do have one coming out for COVID?
No, it doesn't surprise me at all. We know that HIV virus is different from these viruses that you're talking about, the COVID virus and the rest. HIV is one virus that has the capacity and the ability to understand its environment and change it. And as I have been saying, it behaves like chameleon. You see it now is white. If it enters into green area, it changes to become green, and you find it very difficult to target. And that is exactly what HIV is. And that is why HIV is different, and that is why developing a vaccine for HIV has eluded the scientific world for the last 20 years, simply because the virus mutates and it changes its shapes, and you know, it denies you the ability to hit it and continue hitting it in one direction or in one side forever. But other viruses lack capacity to do that, and because of that, once you study them, you can actually come with something that can hit them and can continue to hit them and will do the job for you. So that's the difference. Now, whether the attention to COVID has denied opportunities for HIV, yes, it does, and it's expected. Why? Because HIV doesn't kill immediately. HIV can take 10, 20 years before it kills person, or sometimes 30 years. But COVID kills faster, and that's why the attention is on COVID. And you know that there are certain group that are targeted by COVID and are tricks, you know. But for HIV, this same group, you know, can be affected by HIV and can survive. But if they get COVID, the chances of survival is very, very low. So, and these are people with comorbid condition with advanced age. So that's why the attention is much on COVID at the moment.
Okay, in 2018, you did this remarkable survey, the NICE survey, and got all these, you know, current data about HIV AIDS in Nigeria. It really changed the picture of AIDS in Nigeria. How has this helped the response?
It has response since the time we got these results. Why? Because we now know that we are much closer, you know, to controlling HIV in Nigeria than we have thought before. And we now know that we don't have that much large number that we thought we have in Nigeria that live with HIV as before. And we now know where the epidemic is raging, the locations, you know, where we are seeing cases more than others. So we can now point and kill. What I mean, we can focus on this location and make sure we saturate them. And this is exactly what we're doing. From the time we got these results, you know, we've come up with what we call surge ART. We target these communities where we know HIV is raging and infection is taking place with activities, you know, at community level, at facility level, and is really yielding fruit, because we are getting people now coming out and we are having them tested, and we are identifying HIV positive among them. We are putting them on treatment, and this we are going to continue. This is the momentum we want to sustain, you know, going 2021 and 2022. Hopefully by the time we hit the end of 2022, all those targets that we set to achieve, we will be happy to report that we have either achieved them or we surpassed them.
Oh, that's very good. Let's quickly go back to key populations. And I'm wondering, this self-test, there's an AIDS HIV self-test. Can this be employed to sort of tease the men and key populations to do more testing? And how?
Yes. That right now, that's exactly what we are doing. We're encouraging people to take this opportunity to test themselves and know their status, especially the key affected population. And for the key affected population, we are going to make these kits available and free of charge. For the general population, we are urging our populace to give us the contribution, and this contribution is what we ask for every citizen that is 15 years and above. To know their HIV status and do something about it. We know the number of people that have HIV among the general population is declining, and if you go to test everyone, you're unlikely to be able to have the testing tools that will enable you to test everyone, 200 million people at the same time. But if people take that responsibility upon themselves. And now with the self-test kits, you know, you can take this test by yourself at the comfort of your room. All it takes is it has a stick and it has a tube. The tube has chemical. Just rub your upper gum, you know, with one side of the stick and turn the other side of the stick and rub your lower gum and put it inside that container or that tube that has the chemical and just leave it for 15 to 20 minutes and the result will be out. When you see two lines, then it shows that there may be HIV. And when you see only one line, it shows that this test is HIV negative. So it is that simple now. And this is what we are appealing to all that are 15 years and above. Take time, test yourself, or find where they test for HIV, know about your HIV status, and do something about it today.
That is so remarkable, so simple. And I'm just wondering, I mean, apart from people who might get into trouble with the law, the key populations now, why are we having an issue with stigma?
The stigma, you know, started when HIV came in, and you know, it's expected to continue. But I'm happy to say that we're making progress with stigma and discrimination. People now feel more confident, you know, to come out and test for HIV. People now feel more confident to share their HIV status with you and tell you that, look, I took this test and they told me I'm HIV positive. What do I do? You know, we've made tremendous progress in that, but still we have issues of stigma and discrimination. And you know, we've been lucky. The last 2 years we have this law against stigma and discrimination, you know, which will get someone, you know, who's stigmatized or discriminate either get fined or jailed, or somebody have both, a combination of fine and jail. And we're happy about it. And we're working with National Human Rights Commission to ensure whenever we have such cases, we hand them over to National Human Rights Commission and Association of Lawyers that give us free services, to give free services to these cases to ensure that they are speedily dispensed with, and individuals who are found to violate the law, you know, get the necessary punishment they deserve.
Can you, in 1 minute, tell us about pre-exposure prophylaxis, post-exposure prophylaxis, and whether we use that in Nigeria?
Post-exposure prophylaxis is mainly for health care providers that are at risk of getting HIV, and what they get exposed probably from handling an HIV patient. They feel they get infected. They quickly get this medication to ensure that even if there is an infection, the infection doesn't set in. The pre-exposure prophylaxis is targeted to two groups here in Nigeria. We're looking at discordant couples where one of the couple is positive and the other is negative. So the husband is positive, maybe the wife is negative, or the wife is positive, the husband is negative. How do we ensure they continue to live as couple and they continue to live without the person that is negative, you know, getting HIV? So that's where we have the pre-exposure prophylaxis. And for the key affected population that we know, they get HIV faster than anybody, and they give HIV faster than everyone in the community. So for this group of people, we want to make sure they take proactive measures, you know, to protect themselves, especially those of them that are HIV negative, to make sure they don't get the infection.
Thank you so much, Dr. Gambo Aliyu. It's been wonderful, really wonderful having you after such a long time. Thank you for coming.
My pleasure, Mary. Thank you.
Thanks, everyone at home, for tuning in. Enjoy the rest of your day. I am Mary Alale Yusuf.